Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, and Healthline is where we like to focus on ways to help you live a healthier, happier, and pain-free life. We'll actually be answering any of your questions in the studio today. Those phone lines aren't open yet, but when you do call, make sure you're in a quiet room so that we can hear your question. If you're tuning in on your TV, turn your TV all the way down because we do get a lot of feedback and we unfortunately can't hear your question. So that number is 318-219-4569. That number will also be on your screen right here below in just a couple of minutes. And when you see that, you know that those phone lines are open. Today we're talking about robotic assisted surgery for hernias and other common issues. And here today to talk about this is Dr. Jim Burke, general surgeon with Willis-Knighton. Thanks for being here.
Thank you.
Absolutely, yeah. So you have been with Willis-Knighton, general surgery. How long have you been a surgeon?
Finished my residency in 2000, so since 2000 I've been with Willis-Knighton.
Oh, nice, nice. What is it about surgery that I guess excites you, or that you were interested in? It's
kind of a little bit funny. I guess growing up, one thing that fascinated me, what really kind of sent me into surgery, was my father was a dentist. And one time he showed me a picture of someone who had had their arm cut off in a traumatic injury. And then they showed where they had reattached it. They had sent him to Dallas somehow, and they had reattached the arm. And I thought that was the most fascinating thing you could do with that. And after that, became interested in it with that.
Very cool. So, and you're not really are you ever reattaching arms?
No, not doing anything like that. So but still going into medicine for a different reason. It's still similar in that it's a functional thing. It's a hands-on, I guess, occupation with surgery. That's we do more surgeries and not so much just treating people with medicines the way a lot of other specialties do. But we're actually functionally and doing things with that.
And it's probably really rewarding. It's a pretty immediate thing that you can see. Of course, once you get past the recovery and the pain, it's probably pretty rewarding.
Correct. It is a more immediate thing, and you can see that you fix the problem where a lot of long-term issues, high blood pressure, diabetes, and a lot of other things, the medicine doctors do a terrific job, and they've advanced so far treating those diseases. But it's a long-term disease that you follow, so you see them improving or staying functioning humans with that individuals, and with the surgery you see more of immediate, that problem's fixed and now it's over. With that.
Yeah, very cool. Nice. So with general surgery, can you tell us a little bit about those conditions that you see? In being general, it can be a lot of different things, right?
It can be a lot of different things. Very common thing is taking out gallbladders with gallbladder disease, people coming in with cholecystitis, infection in the gallbladder, or gallstones. Hernias are quite common, inguinal hernias through people who've had previous open incisions. That's one big advantage to minimally invasive incisions, that they're so small you usually don't get hernias. You can, but it's very unusual, as opposed to a big midline incision where you're more apt to get an incisional hernia long term.
Right, and so a lot of the things it sounds like that you treat are typically in that abdominal area, right?
Mostly the abdominal area. Now we do a lot of other things to the extremities for amputations and skin grafts and
which
other trauma to the extremities, but majority is intra-abdominally, correct.
Okay, and with the abdominal, that area of the body, there's so many things that could go wrong, right? There's so many different vital organs.
So many different organs, and that's why you still have specialties within general surgery. Of other abdominal specialties that do different things. You have the urologists who do things, you have the GYN doctors who take care of more female problems, and then you have transplant surgeons who do a lot with that, and we all work together, which is a good thing. We may call one of our colleagues because we think they may be having a GYN issue when we're going to do an operation, or they may call us intraoperatively, or we call them intraoperatively to come help for different things. So it's always a big team approach. It's not just one discipline doing everything.
Yeah, and that's helpful to lean on your colleagues for that. So with hernias, there's many different types. You mentioned one of them, but what are those other common ones you see?
Well, the most common ones are probably inguinal hernias, which are hernias in the groin area, which are very common with that. You can get hernias around your belly button, or what we call umbilical hernias. Those are quite common. Then we'll see incisional hernias, where people who had the previous big incisions will come back and from lifting things heavy, or sometimes the sutures are pulled through. If their abdominal wall is not very thick, or they have a very thin muscular layer, the sutures don't hold very well. Then there's also the ones called hiatal hernias, which is a hernia through your diaphragm when your stomach will go up into your chest.
Ooh.
So you have to pull it back down and close the hole in the diaphragm.
Okay, and how do these hernias come about? You mentioned the incisional ones, so maybe previous surgery, but how do the other ones typically form?
It's a good question. We wish we knew the specific answer to that, and that would help us tremendously. Some of it is lifting heavy objects. As we get older, our fascia, which is the layer around our muscles, can get weaker, and our muscle strength gets weaker, so those areas tend to bulge out. People with chronic coughs from just coughing and coughing, because when you cough or sneeze, you increase your intra-abdominal pressure very significantly, and so that pushes out on these areas. And we have kind of natural openings in that area anyway, because on our diaphragm, the esophagus and the aorta have to go through, and that's right where the stomach is. So there's already a hole there. In men, we have our spermatic cords going through our abdominal walls that have a hernia there. That's why inguinal hernias are much more common in men than women with that.
Okay, very interesting. So, so how would someone know if they do have a hernia, and when should they seek help?
Well, you want to seek help as soon as possible. Most ones in the inguinal area and the umbilical region, you have a bulge that you can feel. You'll feel a little knot, or it'll come out. Sometimes you can lay down, massage it, push it back in, and you can feel a little hole there. Any hernia you have, you'd like to get in as soon as you can to have it repaired, because it's much easier to repair a small hole than a big hole. As the hole gets bigger and bigger, it becomes much more difficult to repair. The odds of it recurring are much higher when it's big with that.
And it can increase in size because of that pressure that builds up?
Increase in size because of the pressure. The natural history of most hernias is that they'll slowly increase in size. Some of them do it very rapidly, others do it very slowly with that.
Yeah, so either way, you want to get it checked
Either
out.
way, and then once you have them and you continue to work, people have very physical jobs, picking up heavy things. Once you have a hernia, you're always increasing that intra-abdominal pressure as you work, and it just slowly stretches those orifices out.
So what about, someone that maybe does lift weights and now they're scared that they're going to develop a hernia? Is there specific things you can recommend for someone to properly lift weights?
Well, proper technique for any kind of weightlifting is the big thing, but there are sometimes we don't know why people end up having them with that. Heavy weightlifting is one, but there are lots of athletes and lots of people who train every day and lift tremendous amounts of weight and don't get hernias with that. So if we can figure out the exact reason why, then we can maybe prevent the others.
Yeah, and maybe some of it could be conditioning if you're not used to it.
Some of it's conditioning, some of it could be genetics on how our bodies are formed, and all of us are a little different, and some of us are just maybe predisposed to that where others aren't.
Very interesting. Okay, well, regardless, you want to get it checked out if you find it. So what about if they, find this bulge, I guess as you call it, and you maybe lay down and you find it? Do they need to call their primary care physician, go to the emergency room? What's the next plan of action?
As long as it's not hurting, they're not having any nausea or vomiting, anything, they can go to their primary care physicians who can evaluate them and then refer them to a surgeon with that. If you find it and you know what it is, and you could just self-refer to a surgeon to try and have that evaluated.
Okay, yeah, pretty easy enough. And you mentioned in our midday newscast that you suggest always to have an elective surgery when it comes to something like a hernia, right?
Correct.
That's the preferred.
There sometimes when the hernias herniate through and you have a large bulge, and if you can't reduce them and you start getting pain or nausea or vomiting, you're getting what's called an incarcerated hernia, meaning the hernia is stuck through that little hole in the abdominal wall. Then the bowel swells and you start to cut off the blood supply to that bowel, and that bowel can die or infarct. And then you have a much bigger problem, because then you have to go in and resect that bowel because it died in that hernia. So any pain, any nausea or vomiting, you need to go to the emergency room very quickly. And a lot of times either the ER physicians can or we can reduce it or push it back in by sedating you a little bit in the ER, where you convert it from not a technical emergency where you need to take them to the OR right then, but then you could do it the next day. If it's 2 in the morning when you come in, you could do it the next day. If you can't and there's a lot of pain, then we have to call out the OR teams and do it in the middle of the night.
Gotcha.
To try and prevent that valve from dying.
Right. Well, we do have our first caller on the line. William, thanks for joining us. And what is your question for Dr. Burke today?
Doc, I have been diagnosed with a hiatal hernia.
Okay.
My PCP really didn't suggest that I go through the surgery because he says it's a very serious surgery. But the surgeon says, to talk to someone about it before I have the surgery. So my concern is what would be the best option for me having a hiatal hernia. It would get larger. It does give me chest pain sometimes. So I'm just lost.
So right now it's bothering you by giving you some chest pain. Do you have any trouble when you eat? Do you feel bloated after you eat or have any shortness of breath?
No, but I do have reflux.
Okay. That's probably contributing to the reflux because part of your stomach is up in your chest and it puts a little more pressure on that upper part of your stomach. And then it kind of forces some of those gastric contents back up in your esophagus and probably exacerbates or makes your reflux a little worse. But yeah, what I would do, I would just go, because there are a couple of tests that we would normally get to evaluate the hernia to see how big it is. One would be a CAT scan to look at the diaphragm. And a lot of times we'll get the GI doctors to look down your throat with the scope to look into your stomach before we do any surgery to make sure that there are no ulcers or anything else in your stomach that could be giving you trouble.
Well, I have ulcers in my stomach also, too.
You do? Okay. But yeah, the best thing to do is to try and get it repaired, and by doing it minimally invasive with either the laparoscope or the robot, now it's less postoperative discomfort, it's less time off of work. As you said, it's a serious surgery. Any surgery is serious. We take them all very serious because the smallest surgeries can turn into something much bigger. You can never tell till you get in there. But I think the big thing. Sorry, go ahead.
Go ahead, I'm sorry. Will my hernia increase in size, or will it just something I can live with?
It will probably slowly increase in size, which is what most hernias do. Now, they do that at different rates. Some do it very rapidly, others do it slowly. But remember, any hernia, you want to try and repair it when that hole is small because it's much easier to repair with that.
Okay.
So I'd recommend.
Thank you, Doc.
Okay, you're welcome.
Yeah, thanks for joining us, William. And if you do have a question for Dr. Burke, you can give us a call at the number that you see on your screen. That is 318-219-4569. And we are talking about general surgery. Hernias has kind of been the topic so far, but other surgical interventions to do with maybe even gallbladder. If you had questions specific to that, give us a call. So you are kind of an expert, I guess, in the robotic technology as well. Do you have to have specific training when it comes to that?
Yes, you do. And you can look at surgeries progressed a long way. Yeah. From way back when it was quite rudimentary. And then the biggest advance we had in surgery for a long time was anesthesia. Once we had anesthesia, then we could progress to more complex operations, more intra-abdominal operations that you couldn't do without anesthesia because of the discomfort of the patient with that. So that progressed to the open surgery. Then we went to the laparoscopic surgery, which is also minimally invasive. And then we get to the robot. Now, most general surgeons nowadays, we went through your general surgery residency. Then I did a laparoscopic fellowship or a minimally invasive fellowship where I had extra training in doing the laparoscopic surgery. Then we did that for quite a while till the robot started appearing kind of in about 1995. We had a robot called Zeus which was a very early rudimentary robot, and then we ended up with the Da Vinci, which has taken us very, very much to the future, I guess you would say. Mm-hmm. So we have now got to the point with the minimally invasive incisions that we can do things that used to require large incisions, where now you can go home the same day or the day after instead of staying in the hospital 5 days to a week to have your gallbladder out.
Wow.
It's day surgery.
Mm-hmm.
And other things such as colon resections, you may be in the hospital 2 or 3 days instead of a week by doing it that way.
That's incredible. And great for the patient, and you're able to help more people as well.
Yes.
Okay, well, we have our next caller, Petey. Thanks for joining, or Dee Dee, I'm sorry. Thanks for joining us, and what is your question? Oh, Victoria, thanks for joining us. What's your question? Can you hear us,
Hi.
Victoria?
Okay, yes, all right. It's just a quick question. If we're local, do we need a referral to see you, doctor?
No, you can self-refer and come in
Okay.
with that.
Okay, good. That's what I need to know. My husband has 2 that needs to be repaired. So.
Okay, good.
All right, yeah.
All right.
All right.
So how can people self-refer? Do they just call your office?
Just call the office, correct, yes.
Okay. Do you have that number, or
It's,
is it easier to just Google you?
212-6070.
Okay, 6070, 212-6070. And just call your office, and that's
Just call
the
the
best
office
way.
and see, yes.
Okay, good deal. Yeah, so that's great for people that are out there that maybe need that help, and you don't need that extra referral, but you can get one from your primary care.
You can get one from your primary care. It's always good to have a primary care doctor and to kind of go through that doctor, because they can follow you for other things.
Exactly.
That you may need.
Yeah. Okay. So with the robotic surgery, going back to that, you mentioned that it's less invasive. You're able to less hospital stay, but we have some gadgets up here. If you wanted to show those off, is that what you use typically in your when you're performing the surgery?
Okay.
Yeah.
Well, one of the advantages. Let me first show.
Okay.
This is a port that we have that goes through your abdominal wall.
Okay.
That we operate through. It's a kind of a plastic port, and you make a little incision in your abdominal wall, then you kind of slowly put this through, and it sits through your abdominal wall.
Gotcha.
As you can see. So then we take the center part out, which goes through, and then the instrument just goes through the port. So with my hand as the abdominal wall, then the instrument can work through the abdominal wall. And that's where you have the small incisions. Now it's maybe a little bit hard to see, but you can see the end of this instrument. It's just a straight instrument. It doesn't move on the end.
Okay.
It's just straight.
Yeah.
With that.
Oh, gotcha.
So what the robot has done, the instruments on the robot on the end are wristed. So what we say is it's like having your wrist, that your wrist will move in different directions, where the other instrument is just straight. The robot instrument can get in different angles now. I'll explain it to it like this. Let's say you have a cast on your wrist where you can't move your wrist. You can still use your hand and you can do a lot, but you can't bend it at the wrist. What the robot has done is suddenly let us bend it at the wrist, so you can get all these different angles to dissect, to be much more precise, that you used to not be able to do because the instruments just would not do that.
And so what you just showed us, is that what you use in the robot, or is that laparoscopic?
No, that's a laparoscopic instrument, because it doesn't have the reticulating or wristed end.
Makes sense.
And it makes a lot of sense in what it does, and it gives you an advantage of the precision for which you can dissect and perform your operations.
Right, yeah, and I think that, some people, maybe when they hear a robot, they get a little nervous, and they're like, I don't know if I want a robot operating on me. But give us some of those pros that you've seen with using the robot, other than what we've heard.
Yeah, well, the robot is a tool, like a scalpel or a hemostat, that we would normally use in any kind of open surgery. The only difference is we are not standing at the patient, we were sitting at a console in the room once the robot is attached with that. And then we can sit down, and by using our hands and the robotic fingers that go in, you can slowly sit there and dissect and perform the operation. So you're still in the room with that, but you're not just scrubbed in at that point. What we have what are called surgical first assistants who are scrubbed in if we need to help change the instruments on the robot, because sometimes we'll change different instruments because the graspers are all a little different, the scissors are a little different. So while we're doing the operation, we may change those instruments out to keep going and progress with the dissection that we need.
Okay, and so since you are performing this in those small incisions, how can you see what you're doing? Is there a way to see inside?
Well, there's a camera that goes in through one of the ports, and the cameras are very high definition 3D cameras.
Cool.
With the laparoscope, which is the other minimally invasive way, it's a 2D screen. You have a 2D screen, but you're operating in a 3D environment. With the robot, you now have a 3D screen and you're in the 3D environment. So the areas of moving the spatial recognition is much more natural that way than doing it with the laparoscope.
Would you say that the robot has helped you as a surgeon become more accurate?
Much more accurate and much more precise on your dissecting, because the ports with the laparoscope going through the port we showed you, there's a little diaphragm to prevent the gas from leaking out that we put inside your abdomen. So as you move that instrument, there's a little drag on that instrument so that the gas won't come out of the abdomen. With the robot, that's completely gone. You can move it very easily, 2 to 3 millimeters, which is a little harder with the laparoscope.
Okay, very interesting. So we've talked a lot about hernias. That's a very common issue that you fix in the operating room. So what about gallbladders? This is another common one, and this one can also become an emergency as well, and we want to prevent that. So what are some, just talk a little bit about those issues that develop from the gallbladder and those symptoms.
Gallbladder issues are quite common. People come in and will have right upper quadrant pain. A lot of this is exacerbated or made worse by eating greasy foods, because the greasy foods cause your gallbladder to contract. With it, you have gallstones in your gallbladder. Then the gallbladder contracts and you try and push those stones through some of the ducts, and then you get pain because it stops that duct up. Some people come in and just get a lot of bloating with meals. After that, they may not have acute pain, but just feel like they're really full and have a lot of gas on their abdomen after eating. People do come in what's called acute cholecystitis, where they have excruciating pain in the right upper quadrant, nausea, vomiting, and you can develop what is called gangrenous cholecystitis, where your gallbladder actually gets gangrene in it when you come in.
Sounds bad.
And we see that not that infrequently, because a lot of people, just human nature is you have some vague upper abdominal pain. You think it's indigestion or that sometimes you have intermittently. It may have it one day and go away, not have it for a few weeks, have it again, until finally one time it becomes very significant and the pain is so bad that you end up coming to the emergency room.
Right, so it's up here underneath your ribs?
Most of the time it's right upper quadrant pain. It can be epigastric or right in the middle, because the gallbladder sits almost right in the middle and just to the right of your stomach.
Gotcha. Okay. So what about, I've also heard that, if someone is on an extensive weight loss journey and they lose extensive amounts of weight, can this also lead to gallstones?
Occasionally that happens to some people, but it's kind of an anecdotal thing. Yeah, you see it with some people, but you don't see it with everyone with that.
So there's possibly some
people have the gallstones before but lose a lot of weight, and it becomes more pronounced with that as they're doing it.
Makes sense. Okay. So with that pain, as soon as you notice the pain, is it good to maybe consult with your primary care physician to get an evaluation first? Or?
Yeah, it's good to see your primary care physician, because there are other things that some of that pain could be. It could be some reflux with that. It could be some ulcer disease. It could be some problem with your pancreas with that.
Okay, and so we don't want to get to that acute pain situation to where you're having to go to the emergency room.
Don't want to get to the emergency room, because if you have cholelithiasis or gallstones and you come in kind of in an elective thing, that you've had one kind of little bout and you figure out what you have, you go in, you perform the operation. It's say more routine with that. When you come in and they're badly infected, It's very hard to find a lot of the structures with that because of the infection. Sometimes they're so infected that we don't even operate. We put a tube through your abdomen into your gallbladder to drain it because the gallbladder is so bad with that.
Interesting. So this is just kind of a funny question, but can you kind of gauge the size that you've seen as far as like those gallstones that you've personally seen when you take out the gallbladder? I mean, I'm sure that you've seen
gallbladder.
lots
I've
of stuff.
seen them roughly the size of golf balls.
Oh my goodness.
With that, and then a lot of them are just the size of marbles. And the peculiar thing about gallstones that you may have someone who has one tiny gallstone in their gallbladder that is just giving them a tremendous amount of pain. Then you have other people that are in the hospital for other reasons, and they get a CAT scan and they look in their gallbladder, and their gallbladder is packed so full of stones you can't get in. Literally have hundreds in there.
Oh my goodness.
And it's never given them any problems at all.
That's so interesting.
But
and so really you treat the symptoms at this point, or?
Well, you treat anyone who you have it, it's best to go ahead and get it out before it becomes real bad, because if the gallstones get down and go through the ducts to try and pass into the bowel where the bile goes, you have other ducts from the pancreas and other things that all come together. If that stone gets stuck in that duct, then you come in and you're 3 times sicker with that, and you can develop bad pancreatitis. Luckily, the GI doctors have become very good about looking down your throat, going up into that duct and being able to pull those gallstones out and clear that duct, because if it stays blocked, it can also damage your liver with that.
Right.
It used to have to be a big open operation to do that, and then you had to have a drain coming out of your side for 3-4 weeks to a month with that. But they have become so good about doing that, we rarely have to do that.
Okay. And since the gallbladder is kind of what's responsible to help break down those greasy or fatty foods,
Yes.
when you get it taken out, do people have a hard time digesting the fatty foods?
Well, normally you get bolus amounts of bile in the GI tract when we eat greasy foods at one of our meals with that. When that's not there in the gallbladder, because the gallbladder acts as a reservoir to store bile. It converts bile from say a real watery fluid to a thicker motor oil type of fluid. And so when we eat, the gallbladder contracts and pushes the bile into our GI tract. When it's gone, you get more of a continuous flow of bile in your GI tract.
Okay.
Most people don't have any problem, tolerate that well. Some people after it will eat a greasy meal or that, and then need to run to the bathroom and feel like they have a bowel movement. Some people have that transiently. A very few people have that chronically, and there's some medicine to help with that.
Okay, yeah, so you might just notice it right after surgery, and then...
Most people don't. Most people
Okay.
have it out and don't even know it's gone.
Well, that's good.
With that, but
Yeah.
just a few percentage of people end up having that trouble. That's
Interesting.
one of the things that we do see.
Okay, very interesting. Interesting stuff. I just can't get over the golf ball sized stone. That's
And
insane.
if you look at the incisions are so small. In order to get those out, we have to actually make one of the port sites bigger to get that gallstone out when they're back. Sometimes you can crush them up with an instrument and not have to do that, but when you can't do that, you have to actually make your little port site incision larger to get the gallstone out.
Very interesting. Okay, well, we have just about a minute left, and you mentioned that number to call if somebody was interested in being self-referred. Can you mention that again for us?
It's 212-6070.
Okay, and where are you located, Dr. Burke?
At Willis Knight North is the main office.
Okay, good deal. And you're always accepting new patients, I'm
Always
sure?
accepting
or you
new
have
patients, yeah.
colleagues as well that may, like you said, have the specialty. So if you can't specifically help them, there's plenty of people at Willis Knight North.
Plenty of people, and we're lucky that we have some really good general surgeons in Shreveport, you know, with that. And we all work together to help each other out with that.
Good deal. Well, this has been very informative, and hope that you guys at home learned something new like I did. Thanks for joining us, Dr. Burke, and thank you for joining us. This will be on our website. That's ktbs.com/podcast, or we're also on Spotify as well. That's Healthline 3. Thanks for joining us. All right.